Okay, James, we can start the exam now, and I'm just going to start by having a look from the end of the bed. could just lift your right arm up for me. And your left arm. I'm now just going to feel the position of your windpipe. Let me know if it's too uncomfortable. I'm now going to assess the expansion of the chest. This will just involve me placing my hands around the chest quite tightly, then asking you to take a deep breath in. Deep breath, and out. And in, and out. I would now like to tap on the chest. James, I'm now going to listen to the chest. If you could just take some deep breaths in and out through your mouth. This time, James, every time I place my stethoscope on the chest, could you say 99 for me?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
I'm just going to more closely look at your back now. Like before, James, I'd like to examine for chest expansion now. So this will just involve me putting my hands tightly around the chest again and asking you to take a deep breath in. Deep breath, and out, and in, and out. James, I'm now going to tap on your back. If you could just fold your arms for me. James, I'm now going to listen to your back. If you could just keep your arms folded and breathe in and out through your mouth for me. And now if you could say 99 for me.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Completes the examination. Thank you very much. You can now get dressed. James, I'm now going to listen to your chest, and I'll be feeling the pulse in your neck at the same time, okay? And sit forward for me. Deep breath in and out. Hold it there. And breathe normally. And roll onto your left hand side for me. Deep breath in and out. And hold it there. And breathe normally.
Heart murmurs are whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow opening. The blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, a pulmonic stenosis has the same characteristics, but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis.
Then we're going to check his L4 on the left side. Quite hyperreflexive. S1. Okay, now we'll be careful on this side. Okay, so L4. Okay, and look, we have some clonus in the leg. We can stop it by pushing on the Golgi tendon organ just above the knee. That's a significant sign of some sort of myelopathy going on or upper motor neuron lesion. So what we'll do here is we'll gently dorsiflex him, we'll check his S1, and it actually activates his L4. He's so hyperreflexive. He's unable to dorsiflex the big toe, he's unable to dorsiflex the foot against the tone there, and his inversion and eversion are about 2+/5. Another very interesting finding, and we'll zoom in on this one, is that he has a very positive Hoffman's test. So I'd like you to relax your hand. Okay? And what you do here is you hold the middle finger, you flick it, and observe the thumb and the index finger coming together. So that's kind of like the Babinski of the upper extremity. The same thing happens on this side.
ऐसे हाथ सीधा करो बेटा। जीभ दिखाओ बेटा बाहर। हाथ ऊपर करो बेटा, ऐसे करो। ऐसे दोनों हाथ ऐसे ऐसे सीधा रख बेटा।
To test for the Babinski sign, run a pointed object from the heel along the lateral aspect of the foot forwards towards the great toe. In a normal human being, it will result in the flexor reflex or grasping of the toes. The Babinski sign or reflex is a pathological reflex and is characterized by extension of the big toe and abduction of the other toes, which is also called the fan sign or signe de levante. In severe cases, the Babinski sign may be accompanied by hip and knee flexion. A positive Babinski sign indicates disturbance of the pyramidal system, either from structural damage or temporary disturbance due to epilepsy or intoxication.
what's called benign essential tremor. And in this disorder, what you'll see is that often at rest, there is no tremor. So with the hand just sitting here, there is little, if any, hand movement. It will become more pronounced with activity. So you'll see a little bit if you reach out to touch my finger, and just touch it, and bring it back. You'll see a little bit of activity and a little bit of the tremor. Now, if I ask to perform an activity, like pouring water into a glass and then raising it up, let's see what happens. Okay, you can see how pronounced the tremor becomes with activity. And if you try to raise the glass up, okay, and you can put it down. So it's quite pronounced. This is not subtle. Other causes of tremor, one common cause that people worry about, Parkinson's disease, for example, often the tremor will extinguish with activity, and there will be a more pronounced resting tremor. In addition, there will be the other features of Parkinsonism, the bradykinesia, the cogwheeling with movement of joints, which is not present in this case.
Go ahead.
Okay. Just another way of demonstrating the degree of tremor that happens with activity in this benign essential tremor would be to ask someone to write something. Try to write your name, or anyone's name.
I sometimes have to brace one hand with the other to do this.
That's great. You can see how pronounced the tremor is and how difficult then to make out the script.
নাম কি তা বাবা তোমার?
নাম আব্দুল্লাহ।
বাবার নাম কি তা?
হাবিবুল্লাহ।
মায়ের নাম?
তাসলিম।
তুমি কিটা কাজ করতে হয়?
কাজে শ্রমিক পাথর।
পড়াশোনা করছিলাই নি?
জিও।
পড়াশোনা।
নাকটা ধরুন তো। আমরা তো সিনি মেয়ে আছে নাকি দেখো তো।
Note the pendulum-like oscillations of the left leg while eliciting this knee jerk.